Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle. Good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
And a quick reminder before we begin, you can always send your questions for Dr. Mingle in a YouTube comment or on LinkedIn or in an email. Send it to hello@minglehealth.com. So our first question for you today, Dr. Mingle, is from Gloria. And Gloria asks, ECQMs and Medicare CQMs are the proposed collection types for APP+. Can you explain the difference between these two options?
Great question, Gloria. You've recognized that in the proposed rule for the Quality Payment Program for 2025, Medicare is proposed to limit the APM performance pathway for accountable care organizations. That's the APM for ACOs, or the APP for ACOs, to the options of ECQMs, that's electronic clinical quality measures, and Medicare CQMs, proposing to eliminate only for MSSP participants the option of submitting MIPS CQMs. If the proposal is finalized, MIPS participants will be able to use MIPS CQMs, just as they always have, ECQMs, or MVPs, MIPS Value Pathways. There are also a couple groups with some additional options. Small practices of 15 providers or less can use claims-based submissions, and facility-based providers can choose to assign the facility's quality score if it has one. Medicare CQMs will not be an option going forward for MIPS participants. MSSP, that is the Medicare Shared Savings Program participants, will be able to use ECQMs or Medicare CQMs. The web interface finally will sunset after the 2024 performance period and will not be an option in 2025 or afterwards. Now, I think it's a big mistake by Medicare to eliminate MIPS CQMs. I expect they will get plenty of criticism for the proposal. Eliminating MIPS CQMs for MSSPs will push back a lot of progress made in value-based care. I'll explain my rationale on this in a future offering. Now, to explain the difference, all quality measures, whether MIPS CQMs, ECQMs, or Medicare CQMs, even claims-based measures, share a similar structure. Each has specifications that describe the patient visits eligible for the measure. Each has specifications that describe the healthcare interventions that qualify as desirable interventions and qualify the patient visit in the performance in the numerator. The output of the measurement is a ratio of the patient visits that got the desired intervention divided by the number of patients or visits eligible for the measure. The methods differ by the acceptable data sources that can be used, the requirements that defines a vendor that's qualified to help you, and the cohort of patients that can be or that must be considered. I'm going to include MIPS CQMs in my description because I'm voting for their continuation, and I think it's an important method. MIPS CQMs permits any accurate data source, whether it's electronic, whether it's manual chart abstraction, whether it's a paper chart, whether it's an EHR, a local clinical registry data set like a cancer registry or diabetes registry. Any place you can find and deliver appropriate data is eligible for use in a MIPS CQM. Now, vendors that provide MIPS CQMs are called qualified registries. They must be qualified annually by Medicare. There are rules and oversight to which they are subject every year. The quality of their work and their measurements are subject to audit, and registries are subject to censure and ultimately disqualification for departures from the requirements. All patients of all payers of participating practices are included in MIPS CQM denominator specifications. Now, Medicare CQMs are a small but significant departure or subset from MIPS CQMs. The population eligible for denominator inclusions is only Medicare Part B patients or beneficiaries. No other patients of any other insurer are eligible for Medicare CQMs. Otherwise, denominator eligibility specifications are word for word identical to those of MIPS CQMs. Everything else matches MIPS CQMs, permissible data sources, vendor qualifications. All vendors qualified to provide MIPS CQMs are qualified also to provide Medicare CQMs. Now, eCQMs, electronic clinical quality measures, specifications that eCQMs must use are formatted differently than our MIPS CQMs and Medicare CQMs. The meaning is the same, essentially to the same set of denominator eligibility and numerator eligibility specifications, but it involves acceptable electronic labels for both denominators and numerators. And the data sources are restricted to electronic sources with a direct path to the certified EHR. So the data has to come from the certified EHR. It has to have the clinical nomenclature that's outlined, and vendors that provide eCQMs are not qualified as our qualified registry vendors, but are certified as our EHRs. Now, qualification for MIPS CQMs and Medicare CQMs comes from Medicare. Certification for eCQMs comes from the Office of the National Coordinator, or ONC. Now, eCQMs must be created by a certified vendor from a certified EHR data source. Now, note that, comparing and contrasting the various methods, qualified registries can use, even exclusively, the same electronic data as do eCQMs. That is, that when we, Mingle Health, who is a qualified registry, produce your submission using only the data from your certified EHR, it's the same data set that eCQMs use. If you recall, in the earlier days of MIPS, Medicare offered an all electronic digital bonus. And we were able to, by choosing to restrict our data to the electronic data set, we were able to get for our clients that digital bonus. Now, eCQMs are by definition digital in nature. They have to use certified EHR data. They have to be certified themselves. Qualified registries can be digital in nature. They can voluntarily or by specification choose to be digital. They can voluntarily restrict themselves to certified EHR data, or they can comply with specifications required restrictions to certified EHR data. Now, they can also use a broader electronic or digital data set than can eCQMs. They can use accurate electronic data that comes from uncertified sources from which eCQMs are restricted. Now, certification requirements are a significant barrier for you as a consumer, as a client. It dramatically increases the expense of quality reporting without improving the accuracy of quality reporting. In fact, certification restrictions can only drive down the accuracy of reporting in a negative way, unfavorable to you, the practice.
Great question, Gloria. Thank you for sending it in. And our next question for you today, Dr. Mingle, is from Jean. And Jean asks, if my specialty has a hard time finding appropriate measures, should I use MVPs?
Great question, Jean. Not necessarily. Now, since Medicare started asking for quality data to be submitted, we've suffered from the phenomenon that there are many practices that do not have adequate appropriate measures that are submittable. MVPs are not designed like specialty measure sets or EMA clusters, that is, eligible measure applicability clusters, to deal specifically with inadequate measure availability. Now, they tend to be as good as specialty measure sets to deal with inadequate measures, or maybe not as good, but similar to, but with a different set of complexities or nuances. Now, let's define those terms, and so doing help you understand the differences in these choices. Starting with EMA clusters. There are a number of measures that are grouped together in defined clusters under similar clinical topics and or eligibility specification. Medicare assumes that if you submit one of those measures, you can submit all of those measures. And if you submit all of the measures in an EMA cluster, you get full credit for a quality submission, even if the measure set includes only 2 measures. Now, it can work even for practices that don't have patients that qualify for one or more of the other measures. An EMA submitter who can truthfully and accurately submit a 0 for the denominator of one or more of the EMMA cluster measures gets a full quality score for the submission. Once you understand specialty measure sets, you'll understand EMMA to be a minor variation or on the specialty measure set concept, typically going more topical where specialty measure sets are more specialty oriented. Now, Medicare defines 51 specialty measure sets for 2024. They are a suggestion, not a requirement for specialty practices. They suggest as a specialty, you go to that specialty measure set to choose your measures. They don't require it. Now, some of the specialty measure sets have fewer than 6 measure choices. There's only a couple out of the 51 with fewer than 6 choices. Submitting all of the measures in the set, even less than 6, counts as a full, unpenalized quality submission. Like EMMA cluster, a practice or provider can submit measures with a 0 denominator when 0 is true and accurate to get full credit for quality. Now, MVPs function in much the same way I just described as specialty measure sets, with some important nuances. Now, submission is limited to the MVP. You can't choose measures beyond the MVP. The MVP is the quality measures in an MVP are coordinated or limited to topically appropriate improvement activities and cost measures. So it also limits or focuses your selection of improvement activities and cost. Well, you don't select cost measures, but an advantage of the MVPs is you only get graded on the cost measures that are connected to the MVP. It closes off the entire universe of cost measures, which the typical MIPS submitter gets subject to. If things continue as scheduled, 2024 will be the last year for which you can use the MVP to qualify your entire practice on quality, just like the 6 measures selected in the MIPS submission today. I think most of my multi-specialty groups are choosing 6 primary care oriented measures to qualify the entire group. Under MVPs, in the first 2 years of its use, you can similarly use the MVP to qualify the entire group. Now, we expected that to be closed after the 2024 performance year. And after 2024, from 2025 and beyond, the use of MVPs were restricted to what's considered the eligible providers, although Medicare is still struggling with how to define eligible providers. Is it by specialty? Is it by eligibility for any of the measures within the group? Is there something else? But they do intend ultimately, after the 2024 year, that MVPs be restricted to the subgroup within your practice that is eligible for the MVP. MVPs are somewhat similar to specialty measure sets. Generally, there are a lot more choices within the MVPs, including choices across methods and an encouragement to use multiple methods in an MVP. You can satisfy an MVP with MIPS CQMs, with eCQMs, with QCDR measures, with claims measures if you're a small practice, or for anyone, administrative claims measures that Medicare calculates for you. So there's a lot more choices, and these measures can become a lot, or these MVPs can become a lot more complex than the MIPS submissions. And you can imagine, you should be aware that as we get deeper into MVPs and it becomes restricted to subgroups, ultimately when Medicare sunsets traditional MIPS and goes fully to MVPs, multi-specialty groups are often going to have to make multiple MVP submissions, not just a single 4-measure MVP submission or a single 6-measure MIPS submission to satisfy MIPS and the quality payment program. Hope this helps. Let me know if I've confused you. I can dig in deeper on any parts of this as indicated.
Thank you, Gene, and thank you to Gloria as well for the great questions. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful. I want to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.